As you see, we have a icon up here. It is embryonic, and the tubes are a blunt tube, and they are not branched. After the 7th week, we will have terminal bronchioles, and we have pulmonary artery veins that they are growing. To this stage, we will see pseudoglandular. And after 17, between 17 weeks until 27 weeks, we have respiratory bronchi and alveolar ducts. And we have primitive alveoli and alveolar capillary barrier. Between the weeks of 17 until 27, a substance is started to be made in the cells that its name is surfactant. Surfactants will be made during the 24 weeks of the embryologic or gestational age, but it won't be secreted in the environment until it reaches about 24 to 25 weeks of gestational age. Well, keep this in mind that we have work with it. So between 24 weeks, little by little, the surfactants will be secreted in the amniotic fluid. And inside, you can find it in the amniotic fluid. Well, between the weeks of 27 to 36, we have gas exchange, and little by little, the alveoli are reformed. And after 36 weeks, we have septation of the alveoli and multiplication of the alveoli. Can everybody see the slide? Yes? Right, very good. Well, now in this slide, and if in case you have a problem, you can raise your hand until I open your microphone. Right. In this slide, we are seeing the embryonic phase. We are seeing that we have just one lung bud and differentiation from the trachea and bronchi. We have to know that the trachea and the esophagus are from one common tube. They are separated. So we have the difficulties that, like a T fistula or fistula between the trachea and the esophagus, is the reason because of their embryologic origin is one. So in the embryonic phase, we see the lung bud differentiation, trachea and bronchi, and pulmonary vein and artery are starting to be shown here. In the pseudoglandular phase, we have conducting airways, gas in our blood. Right. In the canalicular phase, we have primitive alveoli and type 2 and type 1 cells that they start to synthesize surfactants. Right. In the saccular phase, we see that alveolar saccules are here are appearing, and we have extracellular matrix and neural network and maturation. And this is between when? It is between the 27 to 36 weeks. And between the 36 weeks and to 2 years, we have the alveolar phase. That in this alveolar phase, we have expansion of the gas exchange area and nerves and capillaries. So we have to know these because now we have worked with them. Right, in this slide, I want to say some things. That first, it is the you see that we have type 2 cells of the alveolar cells that they are synthesizing surfactant. So between 17 and 26 weeks, the cells will synthesize surfactant, but they won't secrete it. So if a baby is born before this time, surely it will die because we have seen a surfactant, but it's not secreted in the lung. But between 27 to 36 weeks, little by little, the surfactant is secreted inside the environment. And after 36 weeks to 2 years, we are seeing the allolars are starting to septate and they have gas exchange. Right. These are the stages what we have around the allolas. In the slide A, you see the pseudoglandular stage between 6 to 16 weeks. We see the connective tissues and the capillaries, but they are still not connected to each other. And we see the terminal bronchiole that is still blunted. In the canalicular stage between 16 to 26 weeks, we are seeing the terminal sac are little by little trying to be appeared, and we are seeing the capillaries and the connective tissues still there like the previous stage. In the terminal sac, we are seeing that the stage between 26 weeks till birth, we are seeing that little by little these we have elastin fibers. Elastin fibers are very important because they help for the recoil of the lung, and we see the respiratory bronchioles. And between 32 weeks to 9 years, we are seeing that these capillaries are trying to join to each other and they are making the uh, blood lung barrier. Well, this is the cells what we are seeing inside the alveolar sac. You see the alveolar epithelial cell type 2. This alveolar epithelial cell type 2 is that the cell that surfactant is made over there, and it will be it's supplied over there, and after it will secrete it. This is that cell what the famous coronavirus attacks to this cell, and it attaches to its membrane and comes inside, and from inside it will burst the cell. These cells are cuboidal cells, and you see that they are little. Instead of that, we have a second type cell that they are AEC1, alveolar epithelial cell type 1. Well, these cells you are seeing they are thin cells and they are elongated. They are about 10% of the cells, but usually they cover 90% of the alveolar bag. These cells' jobs is that exchange of the blood gases. So they exchange the blood gases. And you can see the capillary that is passing from the airbag, that it brings the CO2 and it gets the O2. And we have elastin inside the alveolar sac, and we have macrophage, alveolar macrophage, that is job that is eating the antigens. Right. The substance what is made during the embryonic phase, its name is surfactant. So what is surfactant? Surfactant is a phospholipidal substance. It's exactly like oil, right? During the stage of the fetal stage, the alveolar ways are all full of liquid. It's full of water. So after the neonates is born, before that, the stage that the water should go inside the capillaries, and the alveolar sac is it is aired. The thing what it happens exactly, we need a substance that it be oily substance that it doesn't let the surface tension let the two part of the alveolar surface they stick to each other. You know, it's like a balloon. If you think that this is a balloon, and if you it's a this is one plastic bag, right? When you blow this balloon like this, right? This is full of water. This surfactant comes inside this environment, and it doesn't let that the water lets that these two parts of the this balloon it come they stick to each other. So it's like an oil that it doesn't let these two stick to each other, and it decreases the surface tension. The components of it is saturated phosphatidylcholine, that is 50% of this component, and unsaturated phosphatidylcholine 20%, and neutral lipids 8%. And we have surfactant type A, type B, type C, and type D. Surfactant type A and type D, their job it is, especially type A, they have an immunologic role, especially in neutralizing viruses and GPS microbes, and their decreases their deficiency. It leads to interstitial lung disease, especially in deficiency of surfactant D. Uh, and surfactant B and C are essential for the surfactants role. So we can see the congenital deficiency of surfactant B and C, but the deficiency of surfactant A and D are not lethal. So the thing what we are seeing mostly in clinics are surfactant B and C deficiency, that they contain 6% of the components of the surfactants. So as I said, surfactant is an oily or no phospholipid component, that it doesn't let the two part or the two surface of the airbag, after the liquid is filled over there, they stick to each other. When you want, you stick the when between the two glasses you pour water, you can't separate them from each other. But when you have oil between them, easily you can separate it. The lung is like that too. The airbags are like that too. We need a component that it doesn't let that they stick to each other. Then this decreases the surface tension, and this is very important for understanding of the rest of the problems. Does anybody have any question until now over here? If there has, please raise his hand until I explain more. No question? I can't hear any noise at all. Anybody does have any question?
No, sir.
Well, have you understood until now here?
Sorry.
Right.
You can go ahead.
Very good. Well, this slide, it shows the recycle of the surfactant. We have a protein ABCA transporter that brings the surfactants inside the Golgi, and it makes the lamellar body. Well, in this lamellar body, we have surfactant B, C, and you see after A and D are added to this situation. This stage you can see between 17 weeks until 24 weeks. This means that if a neonate born before 24 weeks usually dies because we don't have any surfactant in the environment. It's right we have inside the cell, but it's not secreted inside the environment. So they are produced inside the Golgi, and the product is named lamellar body. This lamellar body, it goes into the surface, and from there is excreted inside the environment. And when it's inside the environment, the thing what happens is this, that it's as a tubular myelin, and this tubular myelin, it will be spreaded, and it contains whole of the cell. So it's a tubular myelin that is spreads whole of the cell, and it's a phospholipid, and it makes it a space between the water and the cell. So it won't let that water come to the cell, and it bring these to each other, and it won't let that these two stick to each other. And this is very important role for the surfactant. And as you see inside this slide, we have SPA and SPD that, as I said, they are host defense. So they have host defense role. But SPD and SPC are essential for this surfactant, and the clinics, we have these two deficiencies. Well, this is the surfactant. After it is spreaded, it can again go back to the cell, and it is recycled and again is made, and this cycle will be again repeated. Right, we go to the next slide. This slide is a very nice slide. You can, in this slide, you can see uh, the physiology of the surfactant. In this slide, we see the lamellar bodies. The lamellar bodies, by exocytosis, they go to the surface of the cell, and from there they are secreted. And you see they are making a barrier between the water and the air. So we have a surfactant film, and it won't let that these cells stick to each other and they be collapsed on each other. And they are secreted from where? From pneumocyte type 2. So imagine that if COVID-19 invades these cells and it damages these cells, what happens to the patient? And that's why it's very lethal for the patients. Exchange, the exchange is performed by the type 1 pneumocytes, and you are seeing they are very thin and they are elongated, and they cover nearly more than 90% of the surface of the airbag. This is a very nice slide, and in this slide you can imagine what's going on over here. We have the allolar type CN2, and we see the surfactant and the phospholipids that they make a barrier between the air surface and the water, and we see the antigens and the capillary and the rest. Right. Now, what's going on in the during the embryologic phase? During the embryologic phase, we say, as we said, inside the allular tree, we have water. This means that the water is excreted from the from the embryo to the out, and the embryo produces water. And how this is being done? This slide is showing the channels what we have during the embryonic phase. In this stage, the channels of chloride channels are open. So the chloride goes inside the allular tree, allular tree, and the chloride is secreted from inside to outside. And this means that wherever chloride is going, after that, water is coming back of it. So inside the neonatal, in the embryonic phase or the stage, we have a secretion of chloride from the bags inside the tree, and from there, water will be secreted too. So the embryonic stage, the water is produced, and its direction is from inside toward the amniotic sac. It means that the embryo never swallows water from the amniotic fluid, and the pressure inside the alveolar in the tracheal tree is 2 to 3 centimeters of water higher than the alveolar sac. So the embryo produces water. And why is like this? Because the amniotic fluid, it has many hazardous substances, like what? Like lipase, like the meconium, like pancreatic enzymes. That if the embryo swallows these, they can come inside, and if it aspirated these, they can deactivate the surfactant. So if they deactivate the surfactant, it's lethal for the embryo. And because this doesn't happen, the nature did a work that the chloride channels be open. So the chloride's direction, it is from the alveolar sacs toward the tracheal tree. And after that, wherever we have this secretion, water is after that. So we have a production of water from the embryo toward the amniotic sac. I would like that I see, has everybody understood this mechanism or not? Because this is a base for the understanding of the syndromes. And if anybody has a question, he can ask me. If you need, I will. Excuse me, I can't hear your voice.
Doctor, you can go ahead.
I can
We
go ahead.
understood.
Right. Has everybody understood? Yes? Very good.
Yes, yeah, yes, doctor.
Right. This is exactly that mechanism what I said to you. And we have the directions what we are seeing. Near the I can say the 36 weeks or near the labor time, this pattern changes and is reversed, right? What does it mean? It does mean that during the embryonic stage, we had what? We had the secretion of the chloride toward the mouth. Near the labor, this direction changes, and the channels of sodium are opened toward where? Toward inside the capillary, lung capillaries. So when the sodium is opened inside the lung capillaries, what's going on? It means that these channels are open, so they bring the sodium from inside the airbag and they are transported toward where? Toward the interstitial space and finally inside the lung capillaries. Wherever sodium is going, water is going after that too. So near the labor, the direction of the water is changing. Inside during the embryonic stage, the direction was from the embryo toward the mouth. Now in the labor stage is reverse. It's from the lung toward the capillary of the lungs. And this is the way what the embryo tries to empty the lungs. Well, how this happens? Near the labor, the catecholamine release is increased because of the pain in the mother. Epinephrine and norepinephrine are increased, and this epinephrine and norepinephrine they are connected to the epithelial sodium channels. They open the channels. The sodium is secreted inside the interstitial space and inside the capillaries. So the direction of water is changed and it's reversed, as you see in this slide. The result is that the airbags are going to be empty from what? From water. This is the mechanism what is going to happen near labor. Now imagine if after labor this mechanism doesn't work good and inside the airbags is full of water, what happens? The thing what will happen is this. Because the airbag is full of water, right? The baby starts to what? It starts to push this water toward the interstitial space. How does it do this? With a great cry. The first cry of the baby is for what? Is for one person asked me, this is what's this? این سخنرانی برای استاد I don't know who is it. Ahmed. Uh, This is one English course for the foreign students, and if you like, you can contribute to this uh, lecture, Mr. Ahmed. Is okay? متوجه شدین؟ Right. So, uh, the first try pushes the water toward the interstitial space. If the water is not cleared from the bag, the second mechanism what the baby can do that it protect itself from this water what is gathered inside the air bag, it is this that it doesn't let the exhaled air escapes from the body. So what does it do? It comes and the vocal cords, it leaves the vocal cords semi-closed. It won't let that be closed completely, and it won't let it be remain open. It's semi-closed. When it's semi-closed, you imagine a balloon that you have uh, filled it and you have blown the balloon. And from the tight part of the balloon, you're getting it, and you won't let that the air escapes. You will see one, you'll hear a noise. What's the noise? Such a noise, right? This noise in the neonate, you can hear as what? They will say grunting. Right? So when the baby semi-closes the vocal cords and it doesn't let that the exhaled air escapes from the body, you will hear a noise that this is called grunting. Well, when this exhaled air is trapped in the body inside the tracheal tree, this pushes what? The water. This pushes the water that the water comes in the interstitial space. This is the mechanism of transient tachypnea of neonatal, TTN. Was it easy? Has everybody understood? Right. Well, look, I didn't want to say at once TTN. I wanted to say by mechanism. During the embryonic stage, we said that the direction of water from where to where is it? From the airbag. It's going out toward where? It goes up from the, if I see, I can draw here. Uh, let I see. If I have a blackboard over here, it's much good. I want a whiteboard. Yes, this whiteboard. Right. This is my, and I won't draw. I don't know why. I don't know why I won't draw. Uh, right. This is our airbag, right? These are channels, and this is chloride. The direction is where like what? Like this. So when the chloride is open, the channels are open, the chloride, its direction is from the alveolar bag toward the where? Toward the mouth. So during the embryonic phase, the water's direction is from where? It goes with the chloride. So inside the air tract, we have water. Near the labor, the direction it is reversed. Why? Well, the reason is this. Now our sodium channels are open, right? And the sodium's direction is reversed. It comes inside the interstitial space in here. So the water is after the what? The sodium. Its direction is reversed and it goes out. If you do, and what's the reason? The reason it is what? The reason it is epinephrine and norepinephrine. It means the labor. It means the pain. If you section a mother without pain, right? Because epinephrine and norepinephrine are not increased, sodium channels won't be open. Water is inside here. When the baby is born, we have water, so the alveolar bag collapses on each other. They try to collapse on each other, right? The baby, because it doesn't let that they collapse, it doesn't let that the air goes out. It traps the air inside the tract. So when it traps the air, this pushes the water inside and directs it toward the interstitial space. If this doesn't happen, we are saying this tachypnea transient, tachypnea of neonatal, because it is transient. It's not permanent. Did you understand? Very good. Right, let's close the. Everybody understand? Right, now I have to go back to my. Let's see. Right. Right. Now think that this baby is born and it is grunting. If you want to treat this baby, what you have to do? It's very easy. If you want to treat such a baby, this is the mechanism of fluid in the baby. You have to give a positive pressure. From up, you have to give a positive pressure to the baby until the baby starts to breathe. This positive pressure, how you will give? If you could say, by continuous positive airway pressure is produced by Cpap. What does Cpap do? It gives positive end expiratory pressure. That end expiratory pressure, we call it PEEP. So if you in your book you are reading PEEP, it means that the positive end expiratory pressure. How you will give this? With NeoPuff. That I will in the another session I will talk to you about the resuscitation of the neonates. I will say over there how neopuffs work and how it gives a positive pressure to you. This slide is a very nice slide. In this slide, you can see the fetal site. In the fetal site, you are seeing the chloride that is going inside the space, in the alveolar space, and we have water over there. In the next slide of it, you are seeing in the right-hand side the neonatal phase that the direction of water is reversed. Why? Because the epithelial channel of sodium channels are open and water is directed toward the body. So that's why when there is no water, the baby tries to breathe easier. This is the mechanism of transient tachypnea of neonatal. Well, the final stage of a airbag is like this, that we have exchange between the allele and the blood barrier that it is inside the lung. Well, over here we can see that we in this capillaries we can see we have cytokine release, we have antigens, we have microbes. In congenital pneumonia, these cytokines can go to the other side. It means that from the capillary they can diffuse inside the airbag, and they disrupt the cells, and they deactivate. They will activate the neutrophils. The neutrophils will try to uh, release substances that these they are cytokines, proteases. That these proteases they will try they will do. They will deactivate the surfactant, and they will make pus. So in congenital pneumonia, surfactant is deactivated. We have pus. So whenever the surfactant is deactivated, the two surface of the bag they try to stick to each other. When they stick to each other, we don't have any more uh, exchange, gas exchange. So the baby can't breathe properly. So in TTN, the two surfaces were sticking to each other. Why? Because we had surface tension was decreased because of water. In congenital pneumonia, the two surfaces they try to join to each other. Why? Because of pus and the activation of surfactant. In deficiency of surfactant, what we said that it happens between before 36 weeks of gestational age. In deficiency of that, again, the two parts of the alveolar are stick to each other, and we have no gas exchange. When the baby is going to be delivered, if oxygen doesn't reach to the baby, result is this, that the lower sphincters of the baby are loosened, so the baby releases meconium. And because the baby is gasping because of hypoxia, it aspirates this meconium. When it aspirates this meconium, we said that it has many substances as enzymes, so they will enter the alveolar gas, and again they will deactivate the surfactant. To this they will say meconium aspiration syndrome. So if we want to have a we want to see what's going on in meconium aspiration syndrome, in congenital pneumonia, in TTN, in surfactant deficiency, in these four components, we have deficiency or deactivation of surfactant, and the surfaces of two sides of the bag, it tries to stick to each other. Result, what is it? The result, we have no exchange of blood gases. That's why they call this respiratory distress syndrome, RDS. RDS is not a disease, it's a syndrome. It's exactly like anemia. Anemia is not disease, is a symptom. We have to see what's the cause of RDS. So when we say that the baby has RDS, you have to say the reason of the RDS. RDS is not a diagnosis. RDS is a symptom of a syndrome that by history you have to try to find that what's the real reason of this RDS. Why we call it syndrome? Because the result is this, that when you can't deliver the O2 and you can't exhale the CO2, Result, it is cyanosis. So in RDS, let's go on, we see what will happen in RDS. I have to rub these. Well, in RDS, what we have, the PCO2 increases. Well, if PCO2 increases, we have what? We will see acidosis. So pH decreases. The next thing what happens, because we have no exchange, PaO2 decreases. So we have hypoxemia. So in RDS, we have hypoxemia. So PaO2 decreases. PaO2 decreases. The pH decreases. What's the result? When you don't have PaO2 in the body will start to air hunger. It wants to get more oxygen. So what does it do? It starts to breathe faster. So what we have? We have tachypnea. So the result, one, it is what? Tachypnea. We have tachypnea. We have desaturation because the PCO2 is more and the PaO2 is decreasing. Desaturation. Well, it's difficult to write, but we are saturation, right? We have distress. What is distress? Distress means retraction, intercostal retraction. We have supraglottic retraction, substernal retraction. Why is it retraction? The reason is this. The reason is this, that the chest in the baby, it is barrel shape, like this. These are the ribs. Right. If you want to expand this, because this is barrel shaped, if you put a metal over here, this won't go up easily. Right? But in the adults is not like that. In the adults is like this. The ribs are oblique, like this. So if you put a metal over here, if you little bit push it down, easily this will expand. But in the neonates are not like that. So what happens? These muscles will retract. To this we say retraction. This is retraction, so this is the mechanism of retraction. Is there any question over here? Do you have any question? No question, right. Very good. So we have PCO2 increases, PaO2 decreases, pH decreases, tachypnea, desaturation, retraction, nasal flaring because it increases the air hunger. It increases the air that it comes inside the nostrils. All of these signs in congenital pneumonia, in TTN, in Meconium aspiration syndrome, in surfactant deficiency, all of them, they are one. But their causes are different. We call them respiratory distress syndrome. If in case you are tired, tell that I can finish the class whenever you wish. Or if you want, I can go on. There is no, I have no response. I go on? Right. Well, so until here we understood what's going on. In the neonatal resuscitation, we have a part that is said that if your breathing is by difficult or you have persistent cyanosis, you have to give CPAP. CPAP, it is continuous positive airway pressure. This continuous positive airway pressure pushes the air with a amount of 6 centimeter of water toward the tracheal tree, and it pushes the water, and it acts like this. Look, can you see? It blows this balloon, and it lets from this part the alveol starts to expand, and it recoils, right? One time the balloon, it is like this, it is collapsed on each other, you can't expand this. One time you blow this before like this, and from here it is easily expanded. The CPAP's job is this. So it expands it, it lets that the alveol be easily open and close. This is that stuff what I said to you, the device. This is the device of Neopuff, that with this mask we put on the baby's nostril and we give the positive pressure to the mouth and to the nose. And this positive pressure pushes the water and expands the alveoles, and it lets that gas exchange happens. Right. These are very, well, this is much more important. So respiratory distress syndrome is compounded as hyaline membrane disease. What is hyaline membrane disease? Previously in 1980s or 1970s, that there wasn't any surfactant. They were ventilating the babies mechanically, but you weren't giving the surfactant to the baby. Result was this, that the babies were dying, and in the pathology they thought one orange substance that it was eosinophilic. They called this hyaline membrane disease. Hyaline membrane disease is the time when you have deficiency of surfactant. So previously, when we didn't have surfactant and we weren't giving surfactant to the babies, and just we were mechanically ventilating these babies, after their mortality, in the pathology, we were seeing one substance that we were calling hyaline membrane disease. Now we don't see this term, but because this is from years ago, this is left on this. On the name of the disease. That's why again they are saying hyaline membrane disease, but it's a real one. It is surfactant deficiency. So surfactant deficiency, as we said, you can see from 24 weeks until when? Until nearly 36 weeks, we have surfactant deficiency. So what's the treatment? You have to give the thing what the baby doesn't have. What's that? That is surfactant. How you give it? You will intubate the baby. You will, via from a thin catheter, you will inject the surfactant inside the lung, and that goes to the baby, and it will easily starts to breathe. Uh, this that you will intubate the baby, then you will give the surfactant, and you will take the tube out. They will say, uh, uh, mm, uh, I forgot. I forgot. Now I remember. I will tell you what's it. Right. The second thing what we said, it is TTN, neonatal tachypnea of transient tachypnea, that we said its mechanism. What is it? Then the other one is meconium aspiration syndrome. In the meconium aspiration syndrome, because the baby it's suffering from hypoxia. This hypoxia it causes that the uh, sphincter, lower sphincters, they be loosened, So when it's like that, it passes the meconium, and the baby, during the gasp, it comes and it will aspirate these meconiums. And this meconium first it gives a chemical pneumonia, and after that, after 2 3 days, it will cause a microbial pneumonia. That this deactivates the surfactant, and it causes again gas exchange disorders. That again the baby has distress syndrome. Well, you have to give positive pressure to the baby, and in case you see the baby's really situation is not good, you can give surfactant too, because the surfactant it is deactivated. Well, another thing what we said here is congenital pneumonia, when the mother has infection, or maybe it has UTI, urinary tract infection, or maybe it has PPROM. All right, in these cases, the microbes the baby can ingest during the passage of the canal, or the interleukins can pass from the capillaries of the lung, and they can damage the surfactant, and we have pus over there. So in this case, what you have to do, you have to give antibiotics, and if the baby is in cases were suffering more hard, you have to intubate the baby, and you have to maybe you give surfactant too. So you see that in the hyaline membrane disease or surfactant deficiency, the treatment it is replacing surfactant. In TTN, the treatment it is what giving pressure, positive pressure, Cpap, and meconium aspiration it is Cpap and antibiotics. And in congenital pneumonia, it is antibiotics, and in case maybe you have to intubate the baby and you have to give, in the severe cases, you have to give surfactants too. So you see their manifestations are like each other, but the etiologies are different from each other. So how we should understand? We should understand from the history. In TTN, usually is a term baby, that it has a labor, or the labor it is accelerated, or you have a section without any labor, without any pain. So the baby couldn't push the water out. And after it is born, after 2 hours grunting, the water is pushed and it breathes easily. But in meconium aspiration, you have particles of meconium inside the body, and its result is hypoxia. And in congenital pneumonia, the result it is infection. We have another term of PPHN, pulmonary primary pulmonary hypertension. That I think in congenital heart disease we said the pulmonary arteries are very sensitive to hypoxia. So in all of these components, we have a part of hypoxia. This hypoxia causes that the pulmonary artery constricts. So when it constricts, the pressure in the pulmonary artery increases, and the shunt is direction is from the right to left. It means that because the pressure in the right pulmonary is more than the pressure in the aorta. Let I draw here again. I have to draw, but it won't clean as quickly as possible. Aha, right. This happens. The thing what happens is like this. Let I draw for you. Because we have hypoxia, the thing what happens is like this. This is our aorta. The pressure in the pulmonary artery exceeds, and the direction is from the right to the left. Right to the left. So we have a cyanosis. This is the reason that what we have during when we have cases of RDS syndrome, if they be very severe and we can't treat their hypoxia, we will have PPHN that is very difficult to treat it. Well, these are the categories of the diseases that now I don't want to talk about them. As I said, there are clinical manifestations, and all of these diseases are like each other. That's why we are saying respiratory distress syndrome. But their etiologies are different. Tachypnea, nasal flaring, intercostal sternal recession, grunting, and cyanosis. Well, What should we do with these babies? If you want to handle these babies, we have a score. We call it RDS score. That you see its components: its respiration, cyanosis, retraction, grunting, and air entry. We will give score to these, and based on these, we will decide what to do. Right respiration, lower than 60 breath per minute, it is zero. It does mean it is normal. 60 to 80 is abnormal, we will give one. But more than 80, and or if in case a baby has an apnea, this is severe case, so we will give score 2. Cyanosis in the room, air room, and 0. If it be with 40% of oxygen, we will give score 1. And if the baby needs more than 40% oxygen, we will give score 2. Retraction, if you don't see, you won't give any mark to it. But if it is mild, it is score 1. If it is moderate to severe, you will say score 2. If you can't hear grunting, score 0. But if you put your stethoscope on the baby's chest and you hear under the stethoscope, then you'll give score 1. And if you can hear without stethoscope, it means it's so loud that from the room even you can hear it, you give score 2. Again, you have to listen to the sides of the baby's chest. If you see that the air is coming and going, it is 0. If it is decreased, the noise is 1. If you don't hear anything, it is 2. Right. We will add these. If you have a score less than 5, then the work what you can do is this, that you put the baby under the oxygen of hood, and we have no more work with the baby. But if the score it is between 5 to 8, you have to connect the baby to the Cpap, and you have to give surfactant to the baby. What we do, the thing what I wanted to tell you, it is ensure. Ensure is intubation, surfactant, extubation. You will intubate the baby, you will give the surfactant to it, then you extubate it to baby. So in score 5, you will put the baby under the Cpap, and you will insure the baby, intubate it, give the surfactant to the baby, and extubate it, and put again on the Cpap. In the scores more than 8, you will intubate the baby, you will give surfactant, and we will put it under the mechanical ventilator. This is the way what we act with the baby with RDS. Right. As we said to you, in the RDS, in the respiratory distress syndrome, the final result is this, that the airbags are not aerated, so they are collapsed on each other. When they are collapsed on each other, you will see such a feature. Its reason is this. Look, these little dots are those airbags that they are collapsed on each other. If you connect these each other, this will give a feature to you that you will say fine reticulonodular diagram. Can you see this? Now compare it with this. Look, over here again, exactly these are fine reticulonodular diagram. This is the, so when you see such a thing, right, it means that this airbag, it is filled with what? With water. So the air, what it is over here, it is left behind where? The sac. We call this air bronchogram. And you can see it over here. Let us see, can we find it? Air bronchograms. No, I can't see air bronchogram. It is usually a black dark place, and it is aerated. To that we will say air bronchograms. This is the chest X-ray of a baby with RDS. Well, TTN I explained to you, and its physiology and management and the rest. Meconium aspiration syndrome. We set you what's going on with it. Let I see. Yes, this is this meconium aspiration syndromes checks X-ray. You see, these are the particles of meconium. It's different from RDS. In the deficiency of surfactants, you have one homogeneity in the long pattern, but in the meconium aspiration syndrome, you have particles that is exactly like pneumonia, but is more spreaded than meconium than pneumonia. And congenital pneumonia, and this is the chest X-ray of a congenital pneumonia. So their symptoms are like each other, their practices is nearly like each other, but their patterns and etiologies are completely different from each other. Well, I think for today is enough, and this was a I could nearly say that this was a big part of your book as respiratory distress syndrome, CPAP, and TTN, PPHN, and RDS, and the rest. If you have any question, you can ask me, and I tell you more. Well, the rest, what? If you like, we can continue this program, and if you don't like, we cannot continue. This is up to you. You can tell me later if it was good or if it wasn't. That's again, you can tell me, or if you like to be better, now you can tell me that's much better. If you have any thing to say to me, I'm ready and understandable. Well, thank you very much. If you like for the next time, I don't know what you like. I say for the next time. What's your more interest? Well, until you tell me, and making the PowerPoints is maybe it'll be too late for me. So if you agree, the next week you would like I say neonatal resuscitation for the friends. Are you ready, everybody? Neonatal resuscitation, yes. Does anybody like? It's good, but between them again, talk to your friends and what they like. I talk about that one too. That one week there be time that I make the PowerPoints. Right, very good. Photo from this or not? Well, goodbye, everybody.